Hey everybody, welcome to Ask Dr. Testosterone, starring Dr. George Touliatos, brought to you by his website, gtool.com, gtoul.com. He is the author of Bodybuilding, The Good, the Bad, and the Ugly. You can get that on gtool.com or on amazon.com. He's also a regular contributor every month to Muscular Development Magazine, contributed books such as William Llewellyn's Anabolics. Welcome from Athens, Greece, Dr. George Touliatos. How are you, George?
Hi, Ron. Have a good week. Have a good day over there. Yeah. It's number 11 today.
Yeah, we're rolling.
And before we start, I would like to make a comment about this. There was a lot of talking about the appearance of the Mr. Olympia.
Sean Roden.
Yeah, the current Mr. Olympia, Sean Roden, and how harsh were people on him. Sean Ray, Bob Cicherillo, Nathan Diasha. Frankly, I believe that when you're a Mr. Olympia, you should take care of yourself, even in the off season, of course, and should not be disrespectful for the title and for yourself also, because you have so many contracts and people want to see you improving. And yes, it has to be better in order to win, because there are other guys also that want to take the title. In this Olympia that I will be presented, also it's the first that is so open, there's no favorite. And I think Sean does not look any hungry anymore. It's almost 6 months until the Olympia. It should be start lean out, but
it's 4 months. It's only 4 months now.
I don't believe he gained any more size from last year.
No.
I know Chris Aceto is the best guru out there, and he knows more, but it was really disappointed for his fans. And he didn't have to do this. I mean, he could give a talk or do something else or sign up autographs, but this was something that he was forced to, and he was not pleasant up there.
Yeah, he looked like he didn't want to be there. I know we're not doing Olympia previews, but I can't imagine these other guys like Rolly Winkler, Brandon Curry. They've all been training very, very hard and trying to make improvements these last few months.
I'm a fan of Phil Heath, and I hope Heath will realize that it's about time to come back and take what he lost last year.
That would be awesome. I mean, if he doesn't come back, it's not going to be as exciting. If Phil Heath comes back, this is going to be a very, very exciting Mr. Olympia, because I believe he could get his title back and get tie the record of Ronnie Coleman and Lee Haney. That'd be an exciting, very exciting.
About 7+1, but more or less, it's a great achievement.
Yeah, and maybe he'll add on and get 9 eventually, and that would be the all-time record. Who knows?
We'll see.
We'll see. All right, Doctor, we've been getting some great questions for you. People want answers. You've got them.
Okay.
First of all, what's E2? Before I even start this question, what is that value?
The main estrogen, the main representative of estrogen is beta estradiol.
Okay. So he says, George, my brother-in-law has E2 on 10 and his prolactin raised unexpectedly at age 42. He is not using any anabolic steroids. His endocrinologist told him there's no need for cabergoline, and that will be a waste of money because maybe it's from stress or something. But you said guys with low E2 don't raise prolactin. In this case, I see that it's happening. What's your opinion?
Yes. In another show, I said that when we use 19 testosterone derivatives that have a progestational activity just like nandrolone decaonate and the derivative of deca, the trembolone, they tend to elevate prolactin, and this antagonizes testosterone and causes erectile dysfunction. Now, this is more prone to happen when there's already an estrogenic environment coming from testosterone, coming from other estrogenic compounds like dianabol or equipoise. DECA itself is also slight estrogenic. And we tend to see that when E2 beta estradiol elevates above 50, which is the optimum highest range, then prolactin catches up. The point is, this happens to a steroid user. In this case, there is no estrogen. I mean, E2 beta estradiol is really low. And how much was prolactin? 800?
He did not give a value for prolactin. He just said it was prolactin raised, but he didn't say what it raised to.
Right.
Oh, wait a minute. Maybe that, I'm sorry, he said it raised to 42, and I thought he was saying that the man was 42 years old. So I guess his prolactin is 42.
Yeah. prolactinemia is okay. We can say that it is a moderate prolactinemia of 42 because the highest range is about 15 to 20.
Okay.
In this case, we may use a dopamine agonist like cabergonyl or bromocriptine, but also in order to diagnose and to exclude the case of a prolactinoma, which is a tumor in the hypophysis, in the anterior lobe of the hypophysis, we have to undergo a magnetic resonance image, the MRI, in order to see any possible case of enlargement in the tumor, in the sella turcica of the sphenoid bone. So, yes, some doctors, after the MRI, they see no case of prolactinoma and a benign tumor. Then they believe that lowering stress, insomnia, and a better lifestyle can lower prolactin. Other cases of prolactinemia include medications such as opiates and codeine, SSRIs, antidepressants, hypothyroidism, or actually an elevated TSH may elevate prolactin, and also some other drugs for blood pressure. And as a matter of fact, marijuana, weed, or pot can elevate prolactin, yes.
Oh, wow. It's a bummer. A lot of people smoke pot in the U.S. I don't know where
Yes.
I'm not sure where this guy's writing. Just curious, is marijuana use very popular in Greece or no?
For medical purposes, it does,
Maybe
yes.
for recreational. Do a lot of people recreational?
Yes, of course, but officially it's prohibited. It's as a felony.
Oh, wow.
But the personal use, it's less, blamed.
Yeah, I believe we have recreational use now in 10 or 11 U.S. states, so it's gradually becoming decriminalized.
I think California and Colorado are free.
My state, Massachusetts, it's recreational use is legal now. Yeah, it's actually a few states. But anyway, next question. When I was on TRT, 200 milligrams of Sustanon a week plus HCG and Clomid for 5 months, my sperm count was very low. After being off completely for 5 months while using HCG at 500 IU every other 3 to 4 days, my sperm count bounced back to 40 million. I would like to know if you can keep your fertility when going back on a cycle. 500 milligrams tests plus maybe 400 milligrams of DECA again, and keep using HCG at 500 IU every other 3 days, or will the sperm count still go down and shut down since there is 500 to 900 milligrams exogenous testosterone in the bloodstream? Would love to know this because me and my wife are trying to have a baby, and this can be a large factor.
Yes. Cycling steroids are superphysiological. They have nothing to do with hormonal replacement therapy, that they are within physiological doses. And this also is a fact for the suppression of HPTA. Now, testosterone suppresses the HPTA from day one because it's the hormone that is supposed to be produced. Therefore, you use it exogenously. And either if you use 100 milligrams or 1 gram, the axis shuts off. However, adding other compounds such as DECA, which is a very slow release ester, the anticatenate, will have enormous suppress on FSH. And it's not a good idea to use DECA if you want to have fertility, because it gets rid so slowly from the system that it's found also after 18 months. And suppression is over a year after ceasing the DECA use.
Wow.
Now, it's a good idea, of course, to use HCG plus HMG, but as a protocol for improving fertility, not along using HMG, human menopausal gonadotropin, along with the steroid cycle. Using HCG is wise. I recommend 500 IUs once a week in order to the balls not to shrink and to have a Sertoli function in sperm production, and to prevent atrophizing. And yes, you can also use vitamin E, tocopherol, in high doses of 400 or even 800 milligrams with breakfast. It's a fat-soluble vitamin. And yes, I suggest to undergo a PCT afterwards, and adding also HMG along with HCG, vitamin E, and do a seminal diagram. Now, 40 million, they're not a lot, because the lowest range is 20 million.
Yeah.
And above 50 million, it's supposed to be a better quality sperm. I've heard of also cases of 100,000, 100 million, sorry, 100 million, yes. And but also it's a matter of fertilization. It's a matter of chances also, because ovulation supports fertilization. You know, also the volume of the sperm, not to ejaculate 3 days before the seminal diagram. It matters.
Right. Just curious. You said that DECA would be a bad choice with the test. What about like the fast-acting DECA, NPP?
Yeah, it's a good question, and I'm wondering if this better recover with nandrolone NPP phenylpropionate, because it gets from the system in 2 to 3 days, 78 hours.
So maybe it's more expensive, it's harder to find, and you have to inject more of it.
It's not pharmaceutical. I think it's not pharmaceutical, right?
No. It's all underground. Here's a good one. Doctor, I have doubts about mixing steroids. Can I mix testosterone with equipoise and Vastarel with Testosteronepropionate? Please explain.
Absolutely, yes. I mean, all they can mix up together as long as the half-life of the esters match. Therefore, Testosteronepropionate or Vastarel, the fast release Vastarel, because they're also Vastarel enanthate. Now, the Testosteronepropionate with Testosteronepropionate, they perfectly match. But they have to be used every other day, 3 to 4 times a week. Now, equipoise is the anthocyanate, very slow ester. It resembles the andecaonate half-life of testosterone and DECA. And okay, yes, it can be mixed with testosterone enanthate, because also the enanthate is supposed to be a long-lasting ester like the cypionate.
Yeah.
But definitely it does not match the equipoise with propionate. It's a different timing.
Why would they have to match? I'm just curious, like hypothetically, say I wanted to use testosterone, cypionate, or enanthate. I'll maybe do a shot every 4 or 5 days, and I want to do something like Tren or NPP, which is fast acting, every other day. Would that not be a good idea?
Yes, of course. But Tren will get into the system rapidly.
Yeah.
It has to be used frequently, every other day, the acetate and propionate. And also the benefit of as we said in the very first episode, the benefit of the short-acting esters is that you use more of the substance, because there is a lower percentage of the substance which is attached to the ester. Therefore, 90 milligrams of the trenbolone acetate will be utilized, and only 70 milligrams of the testosterone enanthate will be utilized because of the time release. You know, it's like a vehicle that travels.
So a lot of it gets wasted, these longer-acting esters.
True, but you also, on the flip side is you don't have to inject frequently.
True. Jeez. Damned if you do, damned if you don't. Okay. Here's a good one. Why do you think Tamoxifen doesn't work in PCT? With only Tamoxifen, I restore my natural production of test in 3 weeks. I could send you my blood work after Tamoxifen, only PFC, after Testosteronepropionate, Tren, ACE, Proviron cycle. After PCT with Tamoxifen, followed by Tribulus, DAA, ZMA, a lot of micros, such as extra zinc, magnesium, and high dose of vitamin C. My test was at higher edge, and E2 was a little bit at lower edge. So I guess
this was a question on the YouTube, on the video.
Yeah.
Of course, it does help, but the point is not alone. The SERMs, clomid and tamoxifen, have to be combined together after the use of HCG. And actually, they trick the hypothalamus by lowering the estrogens. Therefore, they trigger for GnRH and LH production afterwards. But you have to use, in first place, HCG in order to boost and to kick the testicles and to increase testosterone production. And afterwards, to use the clomiphene citrate along with tamoxifen citrate or Nolvadex.
Yeah.
Okay. Tapering in lowering the dose. And yes, they have good results. Now, about these supplements, D-aspartic acid, Tribulus, and maca, we use them. And also, vitamin D3 is very promising because it helps in the hormonal system. Nice sleep, of course. Do not stay alert. Do not stay insomniac. high-intensity exercise to produce lactate that also triggers testosterone production. Do not smoke pot or don't drink alcohol during this period. Okay, and sleep from 11 to 7.
Yeah. Okay,
And
so
have as much as you can.
so tamoxifen by itself, not a good choice.
By
for
itself,
PCT.
okay, it's not so promising as when you combine it with clomiphene.
Okay. All right. Next question. Hi there, doctor. Thanks for your information. I have a question. I'm 47 years old. I'm going to make a baby. I'm wondering if I take 50 milligrams testosterone propionate every 4 days, will this affect my sperm?
It depends on for how long he's going to do it. 50 milligrams are actually 1/3 of the TRT dose.
He's taking it every 4 days, so it's almost 100 milligrams a week. I guess it would come out to.
Yeah, actually, it's okay. It's a fair TRT dose, but is he doing this for good? I mean, non-stop? It matters if you follow PCT afterwards. The sperm production and the suppression it becomes gradual. Doesn't mean that you cannot fertilize.
Yeah.
And but if you combine it with HCG and HMG and Proviron also, because Dr. O also supported for Proviron for fertilization issues. This is a tricky part about Proviron. It does suppress LH, but it does not suppress FSH. So I don't think 50 milligrams will be harsh, but the point is for how long he does this. He follows this 50 milligrams. If he follows for 2 months, I believe he's going to eventually manage to let pregnant his wife. Also, according to gynecology, after 1 year of continuous trying, and you not be able to take to have a kid, then you're supposed to be with fertility issues, either the man or the woman.
Yeah.
So it needs in continuously trying over 6 months, over a year, and after you have to realize what's going on.
Well, my question is, if he's taking just enough testosterone, say he's 47 and he's hypogonadal at this point in his life for whatever reason, if he's taking just enough testosterone to put him in a high normal level of the test values, would that affect his fertility or not in a negative way?
So he's 47, he follows a TRT.
Yeah, I mean, let's just say hypothetically that's what he's trying to do. He's using just enough to keep him in a normal testosterone range.
Yeah, when HCG joins the testosterone, then we improve the fertilization possibility. Okay, and this is what happened to me. I mean, I was using HCG every day for 2 years in small doses of 100 IUs. And on the last shot, because it's no longer manufactured, I froze my sperm. It was 60 million. And I started back to 15 million or 20 million. Therefore, yes, we use it alongside in order to improve fertility.
When you say HCG is no longer manufactured, you mean in Greece or like anywhere?
Yes, as Pregneal, because Pregneal was in ampoules of 1,500 IUs. Now we use Ovitrel, which is a pen, but it has to be clicked in certain yes, in order to produce the dose that you want. But in first place, it's used for women that want to get pregnant. But Pregneal was more convenient because the doses you could adjust was better to put it inside the insulin syringe and then, inject as much as you liked.
The pen makes it a very specific dose when you click it.
Yes. You have to adjust and modify the,
I mean, I've seen that with the insulin pens. You turn like a little dial and it click, 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 and it gives you a measured dose every time.
It's like the GH pen, the Ovitrel.
Yeah. Well, boy, everyone loves those. Okay. So, final question. I've never even heard of this, so I'm curious. Hi, doctor. Do you have any knowledge on Vastarel, also known as Trimetazine, as AAS are known to decrease ejection fraction due to left ventricle hypertrophy, and Trimetazine is known to increase it and help stop plaque formation and stenosis. Many thanks. Vastarel, Trimetazine.
Vastarel is a drug is known to help in angina pectoris, which is narrowing of the coronary vessels that give blood supply to the myocardium and oxygen supply, and angina pectoris may lead to acute myocardial infarction. So it's basically it's a vasodilator, the Vastarel.
Okay.
Now, in case of left ventricular hypertrophy, what do we need is first to lower the blood pressure, because blood pressure increases the thickness of the left ventricle. And also we can lower the submaximal heart rate by using beta blockers, just like Dr. O said in one episode. Therefore, in such cases, we use two kinds of medication, antihypertensive and beta blockers. Beta blockers are the opposite of beta stimulants, like clenbuterol. So what is the side effect of beta blocker? You can lower your submaximal, therefore you cannot push it to the limit to 100% of intensity. And also it has an effect on the erectile dysfunction and also in the mood. Also for lowering left ventricular hypertrophy, this guy has to lower his intensity on weights lifting, either mainly to lift lighter, okay, and he has to manage to take care of his blood pressure or also his hematocrit. And the Vastarel does not have any improvement on the atherosclerotic plaque. This is a job done by statins.
Okay. So he would also need to take a statin if he wants to address that issue.
Yes, in case he does a coronary calcium score.
Yeah.
He can watch out if he can clarify he has atherosclerotic plaques or calcium score plaques, stenosis, and manage to fix this.
I got a pretty low score, but I still take a little tiny bit of generic Lipitor every morning, 10 milligrams.
Calcium score or atherosclerotic plaque?
Calcium score, I believe it was a 9.
I have also calcium score. I believe vitamin K2 is the best to do.
Potassium? Is that what that is?
Oh, no, vitamin K2.
What is that?
You know that there are vitamin D3.
Yeah.
Dot K2. Yeah, K2 is supposed to get rid of the calcium from inside the arteries.
Oh, okay.
Because if you use vitamin D3 alone, maybe the calcium that it's get retained from the vitamin D may get into the endothelium of arteries, and then there is a occlusion stenosis.
Okay, so I'll look into that. Vitamin K2. Thank you, doctor.
K2, yes, K2.
Okay. Well, that has been episode 11 of Ask Dr. Testosterone. Dr. George Touliatos, all the way from Athens, Greece, being very generous with his time, his knowledge, his expertise. Thank you so much, Doctor. Guys, please keep the questions coming. We always want new questions, good questions. Leave them in the YouTube comments or go to musculardevelopment.com on the forums and leave them there under the episodes. Anywhere, we'll see them, but especially on YouTube, we'll catch them on YouTube under here. So any questions relating to PED use, how they should be used, how to protect your health, anything you want to know, the doctor is here to help you, and I appreciate it very much. Doctor, thank you so much for your time again. And we will catch you guys on next week, episode 12. Make sure you check out his website, gtool.com, gtoul.com, and there you can pick up this good book, The Bodybuilding, The Good, the Bad, and the Ugly. Very good basic primer on anything related to PEDs. Just about any common question and FAQ that you have, it's covered in there. It's a really good starter education on anabolic steroids and how they're used in bodybuilding. So thank you, doctor. Appreciate your time and wisdom again.
Thank you, Ron.
And everybody, thanks for watching. We will catch you next time.